Good evening, everyone. Today we will be discussing about the test and discussion series 1 that we had with PSM with Ranjith. Before that, I just want you to see this graph. This is the scoring that has come out of all the participants. Those who have not finished the test, you can still access the test. I've put it in the captions below. You can still access it in the Google Forms. Once you've finished the test, you can watch this video. This is just a summary of what will happen in the exam, in the real exam, and this is very close to what can happen actually. A median of 60 points, that means the middlemost person has got 60 as the score among all the participants. I don't remember how many took part, and the range is around 30 to 100, and the average score is 57.5. That means the person who's in the 50th percentile has got the average score also. Now, your aim should always be somewhere to reach here around 80 to 90. There's never a possibility 100 can come, and I got to know how they got this 100 through malpractice. Okay, they have cheated in the exam, they have written the exam twice. This is so close to the reality. So always aim for 80 to 90. If you are somewhere here, good. And if you jump here, maybe in 6 months' time in every subject, you will get a good rank, no doubt about it. So never try to aim for this 100. Good, but if any exams, everything you go around this range, it's good enough. Never be in this range. Slowly come up to your median levels and then hop into the 80 to 90 range. Having said that, we'll go to our first question. Okay, before that, these were the questions which are tough. Which of the following disposal methods is not as per the biomedical? Very contentious question. We'll go through it. Secondary attack rate, yes, that is also a factual based question. So, yes. This was interesting. Addition of common salt to iodized salt. A lot of people, even less than half the people, were not able to answer this. Yes, this type of screening also was a doubtful. A huge number of people couldn't answer that. And yeah, this is a very USMLE type based questions. So it'll help all those who are entering, who are trying for USMLE. So let's go to the questions. First question was, a researcher was studying the association between depression and usage of social media. So there is an outcome, that is depression, and one of the risk factors is social media. Okay. He conducted a study in an engineering college. Okay, when for 6 months by administering the PHQ-9 questionnaire for depression and asked for the history of social media. In this case, it's very interesting. These are all distractors. So always remember, when you see a huge question, focus on the things that actually require attention. That is your risk factor and the outcome. When I say 6 months, he is never saying that there are people who have depression and then he has asked about usage of social media in the past, and then there were people who did not have depression. So there's no chance of it being a case control, right? There were no two groups, nothing like that. Cohort, did he follow up these people and then suddenly find out there is depression in these people? No. What has happened is, you might get confused with this period, 6 months. Okay, so what has happened? Whenever you go and do this question, actually asks if the person has actually done a survey, then you'll realize you cannot do a survey on just one day and then finish it off. Maybe on day one, he went to Raj and Rani. Okay, because the questionnaire might take to administer the questionnaire itself might take some 1 hour or half an hour, who knows. Then he went day two, then day three he took rest, we don't know. And then finally, after he administered among the whole people, it took 6 months. But in essentiality, it was always a cross sectional study, because he's asking at the same time if there is depression using the PHQ-9 questionnaire, and at the same time, he's asking the history of social media to the person. So that becomes a cross section study, irrespective of what time they have given. Now, we'll go to the next question. This is a very straightforward question. Bradford Hills criteria. We have 6 of them: ST, SC, now OBC. This is how I remember. ST, scheduled tribe, scheduled caste, and there is no O, there is B and C. That is strength and temporality, specificity, coherence, biological plausibility, and consistency. Okay, I'm not going to details of it. This is a very straightforward relative risk. What does it show? It shows the association between the cause and effect. How much of an association is there is shown by relative risk, odds ratio. So that all shows the strength of the causality. Okay, one of the most toughest to prove in the Bradford Hill criteria is specificity. Temporality is the most essential to prove, because we need to know if the effect came after the cause. That is basically your temporality. Next question is: a pregnant lady was bit by a rabid dog, was found to have category 3 dog bite. Always remember category 3, it is local treatment of wound, immunoglobulin and vaccine. Now the confusion might be she is pregnant. Always remember the risks outweigh the benefit is always the question, and it is always beneficial for the mother to get the immunoglobulin, and immunoglobulin is always, if there's no contraindication, even the vaccine there is no contraindication. So you just follow the depending on the category. So how do you classify category? Very quickly, it's by category 1 is just touching, category 2 nibbling of uncovered skin minus scratches. The moment you see blood, you call it category 3. Okay, and contamination with membrane with saliva, licks on broken skin. Let's go to the next question. That is 50 children from a slum population were found to have acute lymphoblastic leukemia. Okay, I got a disease here. It was presumed that there was some chemical in the water supply that might have caused the cancer. The rapid response team decided to do a case control study. Okay, association of the chemical to find the association. Okay, these are keywords of this chemical with the occurrence of blood cancer. Children having ALL and exposed to water was taken as cases. Which group will be considered as controls? So we want to match this group. Which is the group that you want to match? Children who have ALL, which is the outcome, and you want to look at the risk factor of drinking the water, exposed to the water. So who will be the control? Control will not have this disease, that is ALL. So that you can rule out two controls, option B, which is having blood cancer, and only option B you can remove. So controls will not have blood cancer. Okay, now children from the same community not having blood cancer, not exposed to water. So you can, if you do that, there is no risk factor involved. Okay, so there's no point, right? You cannot pinpoint that if water was one of the reasons for developing lung cancer. Okay, so next, the control group you can take is not having blood cancer, exposed to water. We'll come to this. Before that, why not this? Children from the hospital not having blood cancer, exposed to water. The reason why we don't want that is maybe they could be other children from other communities who have also been exposed to the water and might not be ideal for considering. The most ideal will be of the same geographical area, not having blood cancer and has been exposed to the water. So this is the risk factor we are trying to look at, and then you can find the odds ratio. The answer for this question is children from the same community not having blood cancer and exposed to water. Okay, now let's go to the next question. There were 4050 births in a year, of which 50 were stillborn. 50 children passed away in the first 7 days, while another 150 passed away in the first 20 days. Very straightforward. What is neonatal mortality rate? Number of deaths in the first 1 month. Neonate is basically not 1 month, 28 days or 28 days divided by total number of live births. Okay, so here what is the number of deaths? We have 150 deaths in the first 28 days, and also you have to include the 50 who died in the first 7 days, because the first 7 days is also part of the 1 month, divided by, there were 50 stillborn, so you have to exclude them, and that you will get 4000. So that will be basically 200 by 4000, which is nothing but 0.05. Now if there was per 1000 live births, I would have multiplied by 1000. That would be 50 per 1000 live births would have been the next answer. Because that is not available, we go for the option D. We'll go to the next question. Which of the following disposal? This is a very contentious question, and problem was this was the option which most of you clicked. Now, always understand laboratory cultures, you can use autoclaving also. Okay, so that is where the confusion was. It is usually non-chlorinated, usually chlorinated disinfectant, but sometimes you also use autoclaving. I would have clicked this if this option was not there. Okay, this is very straightforward. It is deep burial, maybe in PHCs, but ideally incineration, because it goes into the black yellow bag, yellow bin. This also is considered as a discarded medicine, and that will go to incineration into the yellow bin. because it has medicine. This is by special management. You cannot put in deep burial because of harming the environment and exposing other people to radiation. So it's pure logic. If you see these four options, use your sense and see what, before you go and click, okay, this is always chlorinate. Before you go there, look at the other options and see, okay, this can never happen. And this has to be the most obvious answer. Okay, so when you come to radiological waste, there are two types. When the waste has long living isotopes, you do pre-treatment and then it's treated at specialized centers, centralized waste processing facilities. But if there are short living isotopes, meaning the radiation won't be lasting long, then you treat for disinfection, incineration, and those release as municipal waste. You will not release it into the environment directly. Very factual answer. A lot of people made mistakes. It is 90%. Uh, Now, why I gave 90 is I want you to remember, when you look at a number like 90, you can get a lot of information. Like, for instance, 90 within the subject, you can recollect. This is how you use your memory. You keep on connecting things with a simple number like 90. If you tell me what is 90, I will say the SDG goal of TB deaths to be reduced is 90. Is 90% by 2030. One information. I can jump subjects through 90. I can say the resting membrane potential of skeletal and cardiac muscle is 90. Or I can even say that 90-degree abduction is by the deltoid. So this is a trick that comes through time. You have to, and this gives you a revision of like so many subjects with just one letter. Or overhead abduction, more than 90 abduction. That is basically by the teres major and the supraspinatus. No, the serratus anterior. Sorry. I think 15 degree abduction is by the supraspinatus. But yeah, so this is the beauty of learning MCQs. If you just study this, you're not going to remember. But if you keep on like connecting new things, now when you think about TB, you're going to remember this. Okay, 90. I've heard 90 somewhere, or I heard the resting membrane potential. Yeah, I heard it somewhere. So that's the way you learn in NEET or next. That's a trick that will gradually come over time. Now coming to this question, very interesting question. Now look at this. Common salt 2. Always look at it. 2. If I said iodized salt, maybe I would say something like it is specific protection. But now I'm adding common salt and I'm telling to people I'm selling iodized salt. So that is a clear cut violation, and that is obviously it is food adulteration. If I was telling I added iodine to salt to prevent goiter, then it is a case of specific protection, and that is nothing but primary prevention. But if I am educating people about iodized salt, educate about iodized salt, then I would say it is health promotion, and both specific protection and health promotion is a component of primary prevention. Let's go to the next question. A family of patients suffering from diabetes and hypertension was screened for both the disease by checking blood pressure and glucose monitoring. Neighbors came Now, when you hear the word neighbors, oh, let's go, there's a huge mass amount of people. Don't think like that. Let's go to the explanation of it. Um, let's look at the answer to this question is nothing but multiphasic screening. Okay, and I'll explain each one of it in detail. Mass screening means the screening of a whole population or a subgroup. It is offered to all irrespective of the risk status of the individual. Where, like mass screening of CA cervix, of the Kaivara women in the reproductive age group. You took everyone in the reproductive age group who has a risk of having CA cervix, and you have done pap smear, right? So that is a typical example of mass screening. Selective screening is high risk screening among the high risk population. So if you think that NCDs, they are usually more always in the elderly. So you decided I'm only taking more than 60 years, and you are screening for something like diabetes. So that is selective screening. Multi-phase screening is to save time, save resources, where you might be having GRBS and you might be having the BP apparatus, and you don't want to waste time and do only for GRBS, then you come back to the same population and then record the BP. That doesn't make sense. So that is why we tend to uh, when you screen for one or two tests together, then we call it multiphasic screening. Then the last one is anonymous screening, which is usually done in HIV, those kind of diseases, where you don't you want to know what is the status of HIV in the population. Okay, so for instance, there is a place like Tumkur. Okay, now there are so many people. There might be some people having HIV, but they don't want to tell you the status. Nor you. Your aim is to treat those people. Yes, ethically there are questions for that, but you want to know how much in Tumkur it is. So if you keep it anonymous, that person's name is not there, but you have person's ID number or something like that, and you finally get, okay, there is 15%, you can act on it. You can start doing health education, health promotion, and start trying to reduce the HIV status, right? So that is anonymous screening. Finally, we come to the last question, and that is a very interesting question. I like these type of questions. If the value of the screening test was shifted from A to B, which of the following would be true? So first and foremost in this question, understand where is the line. The cutoff point is somewhere here. So if the healthy population is here, that means this region, I mean till here, is negative. Anyone who comes diseased above the cutoff, that is from here, okay, is positive. Okay, now with this understanding, let's go forward. If this is negative, the result is negative, and you are a healthy population, then it is true positive. Correct? Sorry, true negative, because the test is negative and the people do not have the disease. If the test is positive and the people have the disease, then it is true positive. Fine. Now the question is, the person is healthy but the test came positive. That cannot happen, right? So that is false positive. The test result is positive but it is false, meaning that person is healthy but he has come above the cutoff. And the next is the person is diseased but he has come below the cutoff, so it becomes negative. The result is negative but it is false negative. Okay, now the question is, what happens when you So this is almost similar to what we have drawn. Once you find out where the true negatives and the true positives and the false positives and the false negative has to be marked, then it's very simple. In the above question, it was A and B was here, and you have reduced the cutoff. Now let's look at the question on sensitivity. What is sensitivity? For the formula, it is nothing but true positive by true positive plus false negative. Okay. Now when we shift from A to B, it is like you are having a sword here and then you are pushing it here in such a way that all this false negative is going disappearing. So when your false negative reduces, okay, don't worry about these true positive, your sensitivity increases. Okay, so if there is an option that sensitivity increases, then go for that. But what happens to something like negative predictive value? That is nothing but true negatives by true negatives plus false negative. And again, I told you, don't look at this because it's there in the numerator and denominator. False negatives have come down because we have removed it when we come from A to B, and hence the negative predictive value will increase. Now, if you look at specificity, the opposite will happen. What is the definition for specificity? It is true negative by true negative plus false positive. False positives, when you shift, it is increasing. When you shift, your false positivities are increasing. So when this denominator increases, specificity decreases. And same thing with positive predictive value is true positive by true positive plus a false positive. So false positive is increasing and hence positive predictive value decreases. It's that simple. You just have to find out where the true negatives and true positive and think only about this triangle when the shifts all happen, and that will give you an idea of how it goes about. So with that, I end my session. Before that, I had made a mistake in earlier. I just the T, I always remember only the letters. T is not for teres major, it is actually trapezius, which is involved in more overhead abduction. Okay, with that, thank you so much for listening to this session.